So hello, I'm Laura Bachrach, one of the endocrine attendings, and I'm hoping this brief video will give you a little orientation to the experiences in diabetes clinic, how to approach these patients, what the drill is, and try to demystify some of the terminology. My goal here is to make your experience in diabetes clinic more of a learning experience. First of all, the goal of having medical students and residents in the diabetes clinic is to familiarize yourself with a very common pediatric disorder. 1 in 300 children have type 1 diabetes, and our goal is to make you comfortable with this. We do not expect you in 1 half day or 1 month of exposure to diabetes clinics to become an expert, but we'd like you to understand the approach. Our goal is to have you understand how complicated the outpatient care of this disease is for families. We want you to see the complexity of how children react at varying ages, how parents react at varying ages. We want you to see compliant and non-adherent families and get an idea of how complicated the management of this disease is. I'm going through right now the mechanics of the visit in an effort to help you take a careful history and physical in that setting and explain some of the lingo. When our patients come into diabetes clinic, for the majority, they are type 1 diabetics on insulin. A much smaller percent are on type 2 diabetics taking oral agents. The majority, overwhelmingly, will be patients known to our clinic coming back every 3 months, and that influences our histories and physicals. When they check in at the front desk, they will drop off their they will drop off their glucose meters and proceed down to the laboratory to get measurement of their hemoglobin A1C. We will download their glucose meters and present you with a printout of their blood sugar readings over the last 2 weeks. Before they leave the clinic visit, we'll have the results of their hemoglobin A1C, and we'll be able to use those data to guide our advice to the families during the clinic visit. Before you go into the room to see the patient, please review in Cerner the notes from the last clinic visit from the patient to find out how long they've had type 1 diabetes, what the general control has been, what some of the issues have been. So take a look at the last note in Cerner to orient yourself. Please also look at the printout of the blood sugar readings. You'll see there are readings before breakfast, before lunch, before dinner, and perhaps bedtime and 2 a.m. Our goal is that the pre-prandial blood sugars should run between 70 to 80 as a low, and 120 to 130 as a high. And naturally, all the numbers won't be in that range, but take a look how many are out of range high, how many are out of range low before you go into the room. Please also take a look at the height and weight and BMI percentiles before you go into the room. Check the blood pressure. When you enter the room, you'll have a pre-printed form that will give you guidance about what information needs to be gathered. Please, before you start gathering the information on the sheet, ask the family if they have any particular questions or agendas for this visit. This may be a social issue, a child who's non-adherent, who's pushing back against the parents. It may be a diet issue that we'll want to talk to the nutritionist about. There may be a social work issue. Please ask if there are any special questions or concerns for this visit, and then proceed to gather the information. It's important to find out the interval history since last visit. So that's your focus. This is not a brand new patient in most cases. So over the last 3 to 4 months, has the child had any major change in health, any major illnesses, any trips to the emergency room, etc.? What about symptoms of high blood sugar, such as polyuria, polydipsia, getting up at night to drink and void? Anything like that going on? What about lows? How often do lows occur, and does the child feel the lows? It's really important that the child be able to sense when the blood sugar is dropping in order to be able to get help. And in rare occasions, there is hypoglycemic unawareness, which can be very dangerous. After you gather that information, you need to go over the insulin regimen. And this is a bit complicated. I'd like to decipher it. Most patients are on what we call a basal bolus regimen. Now, the basal insulin is the insulin they will require 24/7, even if they're not eating. And this can be either provided as a dose of long-acting Lantus or Glargine insulin given at dinner time, or it can be delivered using Humalog or Novolog short-acting insulin in an insulin pump. but there is a basal amount of insulin that's always required in order to prevent ketoacidosis. So you want to find out what the basal rate is, or the basal dose of glargine or Lantus, again, typically given at dinner time. Then, with every meal and snack, the child is supposed to check the blood sugar and calculate how many carbs they're going to consume. And the amount of Humalog or Novolog short-acting insulin to be given with every meal is determined by those two numbers. They have a so-called insulin carbohydrate ratio, and this is how much insulin they're going to take for how many grams of carbohydrates. And then they have a correction or sensitivity factor, and that's how many units of insulin they need to take to lower their blood sugar. So for instance, in a very young child, their insulin carb ratio may be 1 unit for 30 grams of carbohydrates. They may only take 1 unit of insulin to cover their breakfast cereal of 30 grams. The correction factor may be 1 to 150. 1 unit of insulin will drop them 150 milligrams per deciliter in terms of blood sugars. They need to know those two numbers because those are the numbers that influence how much insulin they take with breakfast, lunch, dinner, and bed. You can then proceed to the physical exam, and the physical exam can be abbreviated. You're going to particularly focus on an eye exam, trying to look in the eyes to see if you see any signs of eye disease. A good eye exam really requires pupil dilation, so take a quick check. Feel the neck for any signs of thyroid gland enlargement or nodularity, because autoimmune thyroid disease is more common in type 1 diabetes. Be sure to check the injection sites. Ask them where they're giving their shots or where they're inserting their pumps, and take a look, because children may overuse certain areas and develop what's called lipohypertrophy, which is an accumulation of fat. It's not only unsightly, but the insulin may not be well absorbed from those sites. In terms of Tanner staging, use your clinical judgment. A 17-year-old boy who's fully mature does not need a Tanner stage at every visit, nor does a 14-year-old girl having regular menstrual cycles. But in some cases where there's been a change in the growth rate or the insulin requirements, it may be appropriate to see if they're moving into puberty. Moving on down the line, we don't take off shoes and put needles in toes because we don't see neuropathies in children with type 1 diabetes. We do see the complications of retinopathy and nephropathy in children who've had type 1 diabetes for 5 years or more. And to deal with that, we tell them to see an ophthalmologist once every year after 5 years. And for the urine microalbumin, it's a good screen looking for renal disease, and we begin doing that yearly after they've had their type 1 diabetes for 5 years or more. Once a year, we check the thyroid function. Once a year or so, we may check lipids, and every couple of years, we'll check for celiac disease, another autoimmune disease that can migrate with the type 1 diabetes. Your most important assessment from the visit is how much do they understand about their diabetes? How adherent are they? How well is it working out in terms of their blood sugars? And what are the stressors going on with the family that make taking care of their diabetes difficult? What I'd like you to take away from the visit is, number one, how demanding this disease is. Number two, how variable it is, the parental role in a young child versus an older child in terms of caring for things. And number three, the types of psychosocial stresses that can impact adherence. We hope you'll get something out of your clinic experience, and by understanding some of the lingo about basal rates, insulin carb ratios, and correction factors, you can focus on these more important big picture issues. We look forward to seeing you in Diabetes Clinic.